Hi, and welcome to today's presentation on normal labor. In this presentation, we are going to look at the anatomy, physiology, and mechanics which are related to labor. Because in order to understand labor very well, we must understand the anatomy and how the pelvis and the fetal head relate to each other to make labor successful. When we say labor, we mean a physiological process during which the product of conception is delivered. And when I say product of conception, I mean the fetus, the membranes, the umbilical cord, as well as the placenta are all expelled from the uterus. Now, when we look at the description of the onset of labor, we say it is a regular painful uterine contraction which occurs every 4 to 5 minutes and must last for 30 to 45 seconds and accompanied by cervical effacement and dilatation. When we say cervical effacement, we mean the taking up of the cervix into the lower uterine segment, and when we say dilatation, we mean the opening of the cervical external os. Now, there are three important components of labor which we must know, and we represent them by the three P's. And so the first P talks about the power, which explains the uterine contractions that the woman will get, and it must occur in every 4 to 5 minutes and last for 30 to 45 seconds. When the uterine contractions are not strong enough and does not last for 30 seconds, then we say labor can be delayed. Now, the second P is passages, and this refers to the birth canal, that's the bony pelvis and the pelvic floor muscles through which the baby will pass to be delivered. And the last P represents the passenger, that is the fetus itself. Now, we are going to spend some time to describe the passages and the fetus in detail. Now, when you look at the bones over here, we see that the bony pelvis is composed of the ilium, the ischium, and the pubis, as well as the sacrum. And you can see that they are separate bones which are fused together. So looking at this diagram, you can see that the ilium is connected to the sacrum at the sacroiliac joint, and the two separate pubis are connected anteriorly or in front by the symphysis pubis. Now, the size and shape of the pelvis can affect the ease or difficulty of labor and delivery, and as such, a broad pelvis gives less difficulty than a narrow one, which may obstruct the descent of the baby down the birth canal. Now, there are certain landmarks of the pelvis which are commonly used to estimate the descent of the baby during labor and delivery. And two of the most important landmarks are the ischial spines, which are over here, as well as the promontory of the sacrum. Now, these are important, and we can actually feel them when we do vaginal examination. Now, when there is a protruding or sharp ischial spine, what happens is that it may arrest the fetal head and prevent the descent of the baby. Also, if the sacral promontory over here cannot be felt on vaginal examination, then the diagonal conjugate, and therefore the pelvic brim, is said to be adequate. But if the sacral promontory is easily felt on vaginal examination, then we say the diagonal conjugate is reduced in diameter, and so the pelvic brim of the pelvis is inadequate to allow spontaneous vaginal delivery. Now, the pelvic inlet is formed by the brim, and we are going to look at some diameters of the pelvis. So over here, okay, this is the pelvis again, but let's look at the diameters of the pelvic inlet. When we view the pelvic inlet from above, this is what we see. The transverse diameter is 13 centimeters. That is from this side to this side of the pelvis. It's called the transverse diameter, and it is 13 centimeters as compared to the anterior posterior diameter, which is 12 centimeters. Anytime we mention anterior posterior. The anterior refers to the symphysis pubis and the posterior refers to the sacral promontory or the sacrum over here. Now, as you look at this image, I want you to imagine that you are the baby in a head down position, looking down on the pelvis from above at the space that you must squeeze yourself through. Now, when we look at this, the next diagram, what we find is that this is describing the pelvic outlet as we view it from below. So the pelvic outlet is also formed by the lower borders of the pubic bone, as you can find over here. So these are the pubic bones connected by the symphysis pubis. So they are connected by the pubic bone and the sacrum behind over here. Now we find the ischial spines also over here, but you cannot see it so well over here, but they are there. Now, as you look at this image also, I want you to imagine yourself as the doctor or the midwife who is looking up the birth canal, waiting to see the fetal head emerging. Now, when you compare these two images, that is the pelvic inlet and the pelvic outlet, what can you say about their dimensions? Which of them is the narrowest? Now, as you can see, we find that the narrowest diameter for the fetus to pass through is the pelvic outlet, which is only 11 centimeters wide, as you can find over here. Now, it is difficult to see from this, but the fetus has to rotate in order to pass through the birth canal. This is because the pelvic inlet is 13 centimeters wide, as we can find over here, whereas the outlet is only 11 centimeters wide over here. So in order to fit through the pelvic outlet, as its widest dimension being the 12.5 centimeters or 12 centimeters, that is in the anterior posterior diameter, it is necessary for the fetus to rotate in order to present its head to the widest dimension of the pelvic outlet, which is the anterior posterior diameter, so that it can be delivered. Now, the largest part of the fetal head is the skull, and so the baby's head first rotates, followed by the shoulders, and the rest of the body will all rotate before it can pass through the birth canal. Now, over here, I have the dimensions of the pelvis, which you can look at your own time and see its importance. But something I want to draw your attention to over here is, if you look at the brim of the pelvis, you can see that the transverse diameter is 13 centimeters. This is because, or this gives it the widest diameter. And over here, what we find is that the fetus also enters the pelvic brim in the occipitotransverse diameter. And so we have a wide enough diameter for the fetal head to pass through the pelvis. Now, when we come here, we also find that the cavity of the pelvis is 12 centimeters all round, and so there will be no problem for the fetus to pass. And when we look at the outlets, we find that it is rather the anterior posterior diameter which is wider as compared to the transverse diameter, and this is why the fetus must rotate in order to assume the anterior posterior diameter so that we can deliver the head. Now, I would like to say something small also about the fetal head. Now, when we look at the fetal skull, quickly, what we find is that these are the bones which forms the fetal skull. So we have the frontal bones, which are connected to each other by the frontal sutures. Then we have the parietal bones, which are also connected by the sagittal sutures. Then the occipital bone is connected to the parietal bones by the lambdoid sutures. Now, where the sutures meet form what we call the fontanelles, and so we have the anterior fontanelle and the posterior fontanelle. The anterior fontanelle is diagonal in shape, or it has four main sides, and it is formed by where the coronal suture, the sagittal suture, and the frontal sutures meet. And the posterior fontanelle is formed by where the sagittal suture, the lambdoid suture meet, and so it is triangular in shape. It gives us an information about the presenting part of the fetus, or the part of the fetus which is being presented. Now, the next thing I want to draw your attention to is some areas of the fetal skull. Now, we have the sinciput over here, which is the forehead. We have the vertex, then we have the occiput, as well as the mentum, or the chin. Now, an important thing that we must know is that the sinciput is the area from the anterior fontanelle to the upper border of the eye. The vertex is the area between the anterior fontanelle and the posterior fontanelle, and the occiput is the area below the posterior fontanelle. These are important measurements that we need to know. Now, when the baby assumes the well-flexed attitude, that is when the chin of the fetus touches the chest of the fetus, the baby assumes the suboccipitobregmatic diameter, which is 9.5 centimeters, and this is smaller enough for it to be delivered, and this is the accepted diameter that we require. Now, when we look at the fetus, what we find is that the fetal skull, when we compare the diameters of the fetal skull relative to the dimensions of the pelvic skull, what do we find? What we find is that the widest portion, or the widest part of the fetal skull, is 9.5 centimeters. This is what I want to draw your attention to. This is 3.5 centimeters less than the widest diameter of the pelvic inlet, as well as 1.5 centimeters less than the widest diameter of the pelvic outlet. What does this mean? This means that if the mother's pelvis and the fetal skull are all having average sizes, then there is sufficient room for the baby's head to pass through the pelvic canal to be delivered. So this is what I want to draw your attention to when we talk about the fetal skull. Now, let's quickly go ahead and look at some other important aspects of the fetus when we talk about labor. And so the first one that we are going to look at is the fetal lie. This is the positioning of the fetus inside the uterus relative to the maternal vertical axis. And so we have three main fetal lies that we can look at. The first one being longitudinal lie, in which the maternal and the fetal vertical axis are parallel to each other. I'll show you photos very soon. Then we have the transverse lie, in which the maternal and fetal vertical axis are perpendicular to each other. Then the last one being the oblique lie, in which we have the lie in between longitudinal and transverse. The baby is not longitudinal, either is the baby transverse, so it lies in between these two. Now, when we look at this image over here, this is the longitudinal line, and in about 99% of the times, we have the baby in the longitudinal line. And when we say longitudinal, we may have it in two different forms. It can be cephalic as well as breech. We have 95% of the time being cephalic, that is the baby presenting with the head, and 4% being breech, in which the baby will present with any other part of the body apart from the head. And so over here we can see that the baby is presenting with the buttocks. Then we have 1% of it being either oblique or transverse lie. And so as you can see in the oblique, the baby is not longitudinal, it is slanting inside the uterus. And when you look at the transverse lie, you can see that the baby is lying about 90 degrees to the maternal vertical axis. So these are the lies that the baby can assume. The next one is the fetal presentation. When we say fetal presentation, we are talking about the part of the fetus which is being delivered first. And so we have the cephalic, in which the head presents first. We have the fascia, in which the face of the fetus presents, as well as breech, in which the buttocks or legs of the fetus present. Now we have different types of breech. We have the complete breech, in which the thighs and the legs are flexed. I'll show you pictures very soon. Then we have footling breech, in which one thigh and leg are extended. Then we have what we call the frank breech, in which the thighs and the legs are all extended. Now we also have compound presentation, in which there is more than one fetal part being presented, and so the fetus can present with either the hand or the feet, which is very difficult presentation. Then we have the last one being the shoulder presentation, in which the fetus presents with the shoulder as the leading presenting part. Now, these are the various presentations that we just looked at. And so this is the normal presentation, in which the baby is coming with the head as in cephalic. Then we have the shoulder presentation, as you can see over here. Then we have the face or the brow presentation, as we can find over here. So the baby is coming with a face, as you can see, a very stubborn baby. Now we have the various types of the breech. So this being the complete breech, in which the legs and the thighs are flexed, but the baby is coming with the buttocks. Then we have the footling breech. As you can see, one leg and the thigh are extended whilst the other is flexed. Then we have the frank breech, in which both thighs and legs of the baby or the fetus are extended. Now the next one we are going to look at is the fetal positioning. And this is the position of the presenting part relative to maternal pelvis. The positioning of the fetus is determined by palpating the posterior fontanelles, which is triangular as we saw. And so the presenting part may be occiput, that is cephalic, mentum, which is face, or sacrum, which is breech. Now, when we talk about the positioning, there are certain key points that we need to know. So when we say occipito-anterior, what we mean is the occiput is referring to the fetal head. So the occiput is for the fetus. Anterior, if you remember, I said anytime we mention anterior, it is in relation to the maternal pelvis, and specifically, we are talking about the symphysis pubis. And so when we say occipito-anterior, we mean the occiput of the baby is directed anteriorly, that is, towards the symphysis pubis. When we say left occipito-anterior, it's very simple. What it means is that the occiput of the fetus is facing the symphysis pubis. However, the spine of the baby is pointing to the left side of the mother. I'll show you photos very soon. And also when we say right occipito-transverse, what it means is that the occiput of the fetus is facing the transverse side of the maternal pelvis. And so the occiput and the spine are all pointing to the right side of the mother. Now let's look at this image to explain it very well. Now, when we look at this image, what do we find? These are the various positionings that we have. And so as you can see, this is the left side of the mother and this is the right side of the mother. Below is anterior and above is posterior. Now, when we say posterior, it is in relation to the sacrum. And when we say anterior, it is in relation to the symphysis pubis. So let's start from here. When we say left occipito-anterior, what we mean is that the occiput of the baby is facing the symphysis pubis. whilst the back of the baby or the spine of the baby is pointing towards the left side of the mother. When we say right occipital anterior, it means the occiput of the fetus is pointing towards the symphysis pubis, but the spine of the fetus is pointing to the right side of the mother. When we say left occipital posterior, what it means is that the occiput of the baby is pointing towards the sacrum. However, the spine of the baby is facing the left side of the mother. And when we say right occipital anterior, we mean the occiput is pointing towards the sacrum, but the spine of the mother is pointing towards the right side of, the spine of the fetus is pointing towards the right side of the mother. Now, when we say left occipital transverse, what it means is that the occiput is pointing towards the transverse, side of the mother, whilst the spine is also pointing at the same direction. So both the spine and the occiput of the fetus are pointing towards the transverse or the left side of the mother. Whilst in right occipital transverse, the occiput is pointing towards the right side of the maternal pelvis, or the transverse side of the maternal pelvis, and the spine of the fetus is pointing to the right side of the mother. So these are the various positionings that the baby can assume. Now, the next one is the fetal attitude. And this is the degree of flexion or extension of the fetal head. So we may have the vertical or the vertex, which is a well-flexed head. And this is the ideal attitude that we want the fetus to assume. And the diameter that is involved is the suboccipital bregmatic, which is 9.5 centimeters. In this attitude, the chin of the fetus is touching the chest of the fetus, and so the head is well flexed. The next one we have is the brow attitude or the brow presentation, and this is when the head is partly extended and the diameter involved is the mentovertical, which is 13 centimeters, and this is a very wide diameter, and so it may lead to obstructed labor since it cannot pass through the maternal pelvis. Then we have facial attitude or facial presentation, in which the head is fully extended and the diameter involved is the submentobregmatic, which is 9.5 centimeters. I'll show you photos of this very soon. Now, when we look at the next one, we have the military attitude. As the name implies, military, head is standing still on the body, and so the diameter is occipitofrontal, which is 11.5 centimeters. And there are various possible outcomes of this attitude. We may have the baby descending with increased flexion, as well as the baby descending with no flexion at all. Then we may also have the baby descending with incomplete flexion. All of these have their own risks which are associated with them, and so the ideal attitude that we want is the vertex. Now, we must also make sure that we give a timely episiotomy when necessary in order to prevent perineal tear as the baby assumes any of these attitudes. Now, the next thing is I want to show you the photos of what we just talked about. And so these are the attitudes. So we have a well-flexed head, which is the ideal. As I mentioned, the suboccipital bregmatic, and the measurement is 9.5 centimeters. So this is how the baby looks like. So this is what we expect. This is the normal thing. The others are when the baby's head keeps extending. And so we have the less well-flexed or partly extended, or the deflexed head, as you can find over here. And this one, as you can see, the head is extended. And so the baby presents with a brow. And the diameter is the occipitomental. Then the measurement is 13 centimeters. Then the last one being the hyperextended or the face presentation. So this is how the baby may present. Now, the next thing that we need to talk about is the fetal station. The fetal station is the descent of the fetal presenting part relative to the maternal ischial spines. And this is expressed in centimeters. And so we have either above the ischial spine or below the ischial spine. If the fetal presenting part is above the ischial spine, it is said to be negative, and if it is below the ischial spine, it is said to be positive. And so the more positive we have, the better chances of getting spontaneous vaginal delivery. Now, when we look at this diagram, this is the ischial spine, and these are the various stations of the fetal head. And so when we do vaginal examination and the fetal head is at the ischial spine, it is said to be at the 0 station. Now, when we find the fetal head above the ischial spine, it is said to be negative. And so we may have -1, -2, -3, up to 5. But when the fetal head descends further beyond the ischial spine, then we have +1, +2, +3. So this may go on until the entire fetal head descends down the ischial spine. Now, in this diagram, we have this to be the fetal head, and over here we have the pelvic inlet or the brim over here, and here being the cavity and this being the outlet. And so as the fetal head passes through, we say if we do vaginal examination and the fetal head is felt beneath or beyond the pelvic inlet, we say it is 1/5. And as it progresses, we have 2/5, we have 3/5, 4/5, as well as a fully engaged head. And over here, as you can see, the fetal head is just below the ischial spine. Now, once we've finished talking about the fetus, let's move on to the mother, which is also very important. Now, we've seen the passages, we've seen the passenger. Now let's move on to the mother and see how some factors contribute to labor in relation to the mother. The first one we talk about is effacement and dilatation. When we say effacement, as I said, it is the taking up of the cervix into the lower uterine segment, and the taking up occurs when the longitudinal muscles from the uterus to the cervix contracts and retracts, and this will lead to the decrease in the cervical length, causes it to become thinner, then it fuses into the lower uterine segment. When we talk about dilatation, it is when already we have a decrease in the amount of collagen, and so together we have increased vascular permeability to the cervix, as well as the interplay of interleukin 8, as well as cytokines and leukocyte infiltration. All these come together, leading to the activation of protease, which causes the degradation of the collagen inside the cervix. And so as the fetal part exerts pressure on the cervix, it causes it to dilate. Now, this is what I mean. Over here, we can see that this is the external os, and here will be the internal os, and this being the fetal head, and this being the uterus. So the space between the internal os and the external os being the cervical canal, which is filled with the operculum. By this time, the operculum is out and the woman is in labor. Now we check for effacement, that is taking up of the cervix. And so as the longitudinal muscles contract and retract, they pull the cervix up into the lower uterine segment over here. With time, we do not find any cervical canal, and so we say the cervix is fully effaced. Then after effacement, we also find the dilatation of the cervix. Now the cervix needs to dilate from 0 centimeters to fully dilated 10 centimeters before we can deliver the baby. And so as you can find over here, we see that the cervix is 7 centimeters dilated, and here the cervix is fully dilated. How do we measure cervical dilatation? We do vaginal examination to estimate the dilatation of the cervix. And so when the cervix can admit one finger, your index finger usually, then we say it is 2 centimeters dilated. If it is admitting 2 fingers, we say it is 3 centimeters dilated. And if these 2 fingers can be open, we assume it has admitted 3 fingers, and so it is 5 centimeters dilated. And so this is how we estimate the dilatation of the cervix. There are other methods that can be used, but this is what I found interesting and easy to explain. Another important thing I want to draw your attention to is what we call the MultiVideo Unit, and this is a method of measuring the uterine performance during labor. Now, when we measure the pressure within the uterus, we do so with an intrauterine catheter. Then, once we get the peak uterine pressure, we subtract it from the resting tone of the uterus. The answer we get, we add it together within a 10-minute period. And so, a normal MultiVideo unit of 200 or more is considered adequate for labor in the active phase. For example, if the woman has 5 contractions which occurred with peak pressure of 65, 50, 55, 45, and 50 respectively, with a resting tone of 10, we subtract 10 from each of these numbers, and whatever we get, we add it together. And so we are going to subtract 10, as you can see over here, and what we add it, and over here we get 215 MultiVideo units, which is adequate for labor in the active phase. There's another method that we can use to do this, which is getting the peak pressure and subtracting the resting tone from it. Then we multiply it by the number of contractions within 10 minutes. And so, for example, if the patient has 5 contractions in 10 minutes, each with a peak pressure of 65 millimeters per mercury, then we have a resting tone of 12 millimeters per mercury, and so we subtract 65 from 12, then we multiply it by 5, which is the number of contractions in 10 minutes, and we get 265 MultiVideo units, which is considered adequate for labor in the active phase. Thanks for your attention. Bye-bye.